Hi, my name is Mani Alikani. I'm director of CTOR, Center for Translational Orthodontics Research, a center dedicated to craniofacial sciences in purpose of advancement of orthopedic treatment and orthodontics tooth movement. Today, I'd like to share another finding of CTOR that significantly changed our understanding in orthodontics treatment for our patient. First, we need to review the biology of tooth movement.
Orthodontic force induces the release of inflammatory cytokines into the periodontal ligament space and increases rank ligand expression by inflammatory cells and osteoblasts residing along the alveolar bone surface. This triggers monocyte macrophage stem cells to differentiate into osteoclasts, resulting in alveolar bone resorption and tooth movement in the direction of orthodontic force. Bone formation by osteoblasts then follows to re-establish the alveolar socket. We conducted a randomized, single-center, single-blinded clinical study to investigate how age may affect this biological response to orthodontic forces. In our study, subjects were divided into two age groups, adolescents and adults. All subjects had fully erupted maxillary canines in a Class II Division I malocclusion requiring maxillary first premolar extraction and at least 3 millimeters of distalization. 6 months after premolar extraction and after leveling and aligning, the center of resistance for the canine and first molar were estimated from radiographs, and two power arms were fabricated to allow application of the force close to their center of resistance. Canine retraction began by connecting a calibrated 50 centinewton Nitite closing coil spring between the arms. To evaluate the level of inflammatory markers, gingival crevicular fluid, or GCF, was collected from the distobuccal gingival crevice of the maxillary canines at the following times: Day 0, which was prior to treatment, and days 1, 7, 14, and 28 after the beginning of retraction. Cytokine and osteoclast marker levels were measured using a custom glass slide-based protein assay. We found that each of the cytokines peaked at day 1 and returned to baseline by day 14. Can you guess which line represents the adolescents and which represents the adults?
So that was a surprising result. We were expecting that young patients would have a stronger inflammatory response to the same orthodontic force. However, the adults showed a stronger inflammatory response and a sustained level of inflammatory markers.
Found a similar pattern of expression for the osteoclast markers, with adult patients showing higher levels of rank ligand and MMP9 expression.
What happens to tooth movement? Which group do we expect to show more movement? Adults or the adolescent group?
To measure the tooth movement, dental casts from the subjects were analyzed. Lines that divided the lateral incisors and canines into equal halves were drawn on the palatal surface. 3 points along the lines were marked to indicate the incisal edge, middle of the crown, and cemento-enamel junction. The amount of tooth movement was calculated based on the measurements of the average distance between the three landmarks on the ipsilateral lateral incisor and canine at each point. Our results show that overall tooth movement was faster in adolescents than adults. In addition, tooth movement for both adolescents and adults was faster during the second half of the study period.
These results are interesting. Even though adults show a more robust inflammatory response to the same orthodontic force, there was more tooth movement in the younger patients. How can we explain that?
There is a biological barriers in adult that children, they don't have that. Adults have a higher, more dense bone around the tooth. For the osteoclast to be able to get rid of this bone, to be able to make a space for the tooth to move, it takes longer. So even though we have a higher inflammatory markers, higher number of the osteoclast, the time to takes for this bone to be replaced, resorb, and make a space for the tooth movement, it takes longer. The next things that we need to look at it is the response of the adult to the pain and discomfort.
We asked patients to assess their discomfort during treatment, beginning immediately before canine retraction on day 0 and on days 1, 7, 14, and 28. They used a numeric rating scale with 0 indicating no pain and 10 indicating the worst possible pain. As expected, Adults self-reported higher discomfort each day compared to adolescents, with days 1 to 14 being significantly higher.
So what is the clinical application of this finding? First, different patients respond differently to orthodontics forces. Age as one variable specifically can determine this response. If adults demonstrate higher amount of inflammatory markers, higher sensitivity, it tells us, as a clinician, we should use lighter force specifically in adult. Second, we should expect less magnitude of the tooth movement in adult in compared with our children. Third, the response of the individual also will different, same individual, during the months. In another word, in the first month, maybe you don't expect that much of a tooth movement. In second month, the rate of tooth movement increase more significantly. The variety of the biological response is not only between the individuals, also in the same individual in different months, you will expecting different biological response. All this can be explained due to the bone density. As the bone density differs, the response from the inflammatory markers to the biology of tooth movement will be different.
In conclusion, orthodontics should move towards personalized care, where the forces should be selected based on the biological response of our patients. This will prevent unnecessary pain and discomfort that doesn't result in increased tooth movement.